currently the medical director of the Hyperbaric Unit at Vancouver General Hospital, where he has worked as an emergency physician and a hyperbaric and diving medicine specialist since 2004. And he's also head of the a specialist in the continuing professional development with the BC Emergency Medicine Network, where he's focused on the creation and delivery of situation-based training programs throughout BC. And he's been the recipient of the UBC Teacher of the Year Award in 2012 and the Innovation Award at the Continuing Professional Development League in 2013. So he's been, I think, has a distinguished career working in the area of emergency medicine and hyperbaric treatment. He, in addition to that, he's on the board of directors of the Mona Foundation, a charity that supports global alleviation of poverty and sustained community development. And Dr. Khazei has volunteered on several occasions to provide medical services in Honduras, in China, Nepal, Vanuatu, around the world. And currently, he heads, as I said, the Hyperbaric Unit at VGH, and is a part of a team of physicians and nurses and technicians who provide a wonderful service for those of us who need it. And it turns out there's more of us than I had imagined. So without going any further, I'd say welcome to you, Dr. Khazei.
Norm, thank you so much for that very warm welcome. And thank you for all of you for actually inviting me and for the opportunity to connect with you and spend this time with you. I also just want to acknowledge the service that your group is doing in supporting and advocating for cancer survivors. It's very purposeful work, and I just really thank you for, committing that time to do service for your, fellow human beings. Before I, start the screen share, I might just kind of mention, I think that some of that noise might be coming from just having the microphone on and then just shuffling papers or using the keyboard and all that. So if it's possible just to maybe mute until you're going to ask a question, it might help reduce that background noise. It can be distracting for everybody. And then I also want to just, I'll start my screen share here, and hopefully this works for all of us. Can you see my slide?
Yes.
Just not yet. Perfect. And, I really kind of fully acknowledge the limitations of Zoom. It's a great way to connect, but also, I'm not in the room with you. So please keep your videos on. And if, exaggerate your facial expressions, lean in to frown, smile, look angry at me if I'm saying something you're not happy with. But, I think that really helps to give me some energy, actually, to kind of really feel like we're able to connect in this way. And also along those lines, feel free to use the chat box for questions. And then also at the end, I'll definitely leave some time for answering your questions if you would rather just ask them verbally. Okay. So, and then I'll also apologize ahead of time if I use medical jargon that doesn't make sense. Please feel free to put it in the chat box, or interrupt me and let me know if I use some terminology that does not make sense. That's easy for medical people to do that. So, I'm calling in from Vancouver General Hospital today. I'm actually in the Hyperbaric Unit. So I want to just acknowledge that, I'm presenting to you from the territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. And I think my potential conflict of interest disclosures, they were mentioned in what Norm shared. The charity board that I serve on and the nonprofit organization that I serve on the board of directors for, I don't believe there is anything that from there that would create a conflict of interest or I do wear a few different administrative hats, including being the Chief Medical Health Officer for Seymour Medical Group, which is a large physician health group in Vancouver. So, you know, I received a list of questions from Norm, which I was very grateful for in trying to make this relevant, this presentation relevant for you as prostate cancer survivors. And so, although the field of hyperbaric diving medicine, it's a big field, I'm going to focus on the issue of delayed radiation injuries. And so, to give this context, you know, about half of all cancer patients receive radiation at some point. This is about 60,000 Canadians annually, and half of them will be long-term survivors. And we know that distinct from acute radiation injury, which happens right away, there is this delayed radiation injury or damage to the tissues that starts to develop anywhere from 6 months to years after the radiation's finished. And this is particularly, you know, can be very discouraging because at this point, you know, folks have gone through so much to beat the cancer, and then this other new issue arises. It is a dose-related issue. So generally in doses of total accumulated radiation between 6,000 to 7,000 centigrades, there's a reported anywhere from 1.8 to 5% risk. And at higher doses over 7,000 centigrade, it's up to 9% reported. And really any part of the body that's irradiated can be affected. So actually, you know, a common area that we see is patients with squamous cell carcinoma of the throat and the mouth that have radiation to the head and neck. They get issues with their jaw and oral cavity getting late radiation effects. We get breast cancer patients that have developed chest wall tissue and bone breakdown. And then in patients that have had pelvic radiation, such as for prostate cancer, cervical cancer, the two most common ones, they develop radiation cystitis, bladder radiation effects, and radiation proctitis and enteritis. So that's delayed radiation effects affecting the bowel. And then in much less commonly, we see people with spinal cord radiation effects, which is quite devastating, and then with brain radiation effects. So, so this condition of radiation cystitis, you know, the acute radiation injury usually resolves within 1 to 3 months. And so we're talking about a condition that's coming on typically after 6 months and most frequently after 2 years. So, you know, and so you can imagine that if the person that is helping you with it is not familiar with this condition, it may sometimes get misdiagnosed as other things initially in the initial stages, right? So that's one thing to kind of keep in mind. So the acute radiation symptoms right after radiation, the urge to pee more frequently, pain with urination, getting up frequently at night, and pain in the pelvis, and resolves within 4 to 6 weeks. Late radiation effects cause a few things to happen. The bladder wall thickens, reducing the volume capacity of the bladder. And so this leads to a sense of urgency and having to go right away and peeing more frequently. There's also loss of the elasticity and the smooth muscle kind of stretchability of the bladder. And then there's also bleeding. And that bleeding can sometimes cause clots and obstruction. And sometimes there's also scarring and fibrosis, which causes narrowing of the drainage. And so retention of urine, bleeding, retention leads to infections. And these have significant quality of life effects. And I think one of the things that we hear commonly is people who were formerly very active with sports and hiking and things, that often there is triggering and increased bleeding, worsening of their symptoms after vigorous physical activity, which starts to become aside from the pain and the urinary symptoms themselves, it becomes a very important limitation on quality of life. So as far as treatments for this, there are a number of bladder irrigation treatments, which usually start out with just irrigating the clots and blood out of the bladder to relieve obstruction. So that's just done with salt water, and that's fairly benign. And then if the bleeding is heavy or continues, there are approaches to try to limit the bleeding. And some of those involve instilling chemicals in the bladder that effectively cauterize the bleeding blood vessels chemically. So this is sort of like with things like silver nitrate, formalin, hyaluronic acid. So these are things that they're a chemical sclerosing agent. They actually kind of chemically burn the lining of the bladder to stop bleeding, which can sometimes be life-threatening. When those fail, there's also an approach to go in with a cystoscope and actually apply heat cautery to burn the blood vessels that are visible. And then in more dire cases, there is a radiologic approach to doing an angiogram of the vessels, seeing which vessels are bleeding, and then injecting items into the vessel to block the vessel, to actually stop the bleeding from upstream. So you can imagine all of these things are traumatic. And what we'll talk about later is that the tissue in its late radiation effects, it's already got a very poor healing potential. So its ability to heal and recover after even seemingly minor trauma is limited. So all of these treatments are, they certainly don't deal with the underlying problem, but they also sometimes trigger more trauma and more bleeding in a vicious cycle. And then in very severe cases where patients are having life-threatening bleeding and transfusions and all these other things have failed, then a removal of the bladder surgically ends up being the kind of last remaining option as a life-saving measure. So what I'm going to share with you a little bit today is some of the literature and the evidence around the use of hyperbaric oxygen therapy, which I will propose has actually got the strongest level of evidence for resulting in consistent and meaningful effects for this condition. So the goal of hyperbaric oxygen treatment is actually to try to restore the irradiated tissue back to more like its pre-radiation state. Okay, so they're trying to reverse some of the damage that's occurred to the tissue that's preventing it from healing itself. And the ways in which it does this is restoring vascularity, stimulating new blood vessels, healthy blood vessels to grow back into the tissue, and also increasing the number of healthy cells that do tissue repair, fibroblast cells. And it also does boost the immune function in the tissue as far as infections. So we'll unpack some of these a little bit more. So now I'm going to kind of get a little bit granular around the mechanisms by which this is going to work. Hyperbaric oxygen stimulates in irradiated tissue release of nitric oxide, which stimulates new blood vessels to grow. And it mobilizes stem cells, which are kind of immature cells that have the potential to develop into healthy new cells that are more mature. It mobilizes more of them to be present in the tissue. And then it also provides in tissue that does not have basic oxygen needs being met because of the damage, it provides oxygen level at a level where the tissue can start to heal. So here's so some of the effects that are happening with hyperbaric are that we know that oxygen levels below 30 millimeters mercury in the tissue prevent basically healing to occur. That's a threshold at which healing can't occur if the oxygen levels are less than 30. The other thing that we know needs to happen for new blood vessels to grow in is there needs to be a differential or gradient between surrounding healthy tissue and the damaged tissue. So I'll show you schematically what we mean by this. I'm going to just put this on the side here. Okay. So you can see that normal tissue, if you get an injury, so this is where, like, let's say before radiation, there's some damage to the bladder lining for some reason, like maybe from a catheterization of the bladder or a biopsy of the bladder. There would be that injured area at its focal point would have very low level of oxygen because there's been a disruption of the blood supply. And then the surrounding tissue would have normal oxygen level, even just when you're breathing air, right? And then there's this gradient of, say, 50 in the normal tissue down to 5 in the traumatized tissue. This gradient's actually important in stimulating new blood vessels to start to grow in. Okay, your body sees that there's a problem here and it addresses it with new blood vessels starting to grow in. When the tissue has been irradiated, you've got this whole irradiated area that chronically has suboptimal oxygen levels because of damage to the blood vessels. And so let's say that hypothetically, in this case, it's at 20. And then you get some kind of trauma here, right? Where it makes that traumatic area have the 5, like you had with the injured area here. This gradient of 20 to 5, it's not a big enough gradient that your body sees it. And so there's not factors released to try to stimulate new blood vessels to grow in. There's also, we were talking about 30 millimeters mercury being like a minimum kind of baseline supply of oxygen for the worker cells in this tissue to start to rebuild. They don't have that supply. And so they can't start to lay down a framework for tissue repair and replication of cells and fighting infection in the tissue while it's healing. So now when we take that irradiated tissue that we were just looking at and we add hyperbaric oxygen, the hyperbaric oxygen, it's a systemic therapy. So you're in, I'll show you the pictures of the hyperbaric chamber later, but basically you're in a room that's pressurized to 2.5 times normal atmospheric pressure. You breathe 100% oxygen. That oxygen goes in through your own lungs, and then it's passed through your circulatory system all over your body. And so we end up raising the systemic arterial oxygen levels to about 2,000 millimeters mercury, okay, which is much, much higher than normal. So at a tissue level, that manifests as, say, sort of in the 350 to 500 oxygen range while you're getting that pulse of oxygen. And so even though the irradiated tissue is compromised, it's not getting the same as the normal tissue. It still gets a lot more than the 20 it was getting because of the radiation damage, right? This now creates 2 things. One, it's exceeding that 30 millimeter threshold that's required for healing to occur and to lay down collagen matrix. And then it also establishes a gradient that's significant. So your body sees it. And then neovascular angiogenesis, new blood vessels growing in to the tissue. And so what are the outcomes for this? So again, there's a lot of studies if you look at like head and neck cancers and other parts of the body, but I'm just going to focus in on radiation, bowel, and bladder. There are a number of studies out there, but there was a recent, in 2020, systematic review, which was done to look at all the studies, eliminate any that were poor, very poor quality, like that weren't really useful, and focus in on, they found 20 studies, and from those 20 studies, they pooled 815 patients. And they looked at their outcomes, and they found that the overall response rate of patients having either improvement or complete resolution, their symptoms was 87.3%, of which, so 65% of patients had a complete response. And so about 22% had a partial response. They also noted that the side effect rate was 9.6% from hyperbaric oxygen therapy. Most of these are related to ear equalization, which is the most common. 10% of patients in our unit have difficulty equalizing their ears with pressure changes and need help with that. So that probably makes up for the majority of this. The effect, it was rare that there would be any serious side effects, but I will also go over later with you what are the side effects. I think really the main limitation they acknowledged in the study was cost of treatments, a time commitment for patients to undergo a course of treatment, and lack of availability in all areas for this treatment modality. The other condition that prostate cancer and other pelvic radiation patients may experience is delayed radiation effects to the rectum, like the distal part of the bowel or other parts of the bowel that are in the pelvis. And so this was a publication that looked at 150 patients. It was a randomized, controlled, double-blinded crossover trial with long-term follow-up. So it's actually in medicine, it's hard to do studies with long-term follow-up. But so this was a well-done study. And so the double-blind part means that the patient's evaluations were done by investigators and other physicians who weren't aware of whether the patient had received hyperbarics or a placebo. Okay, and the placebo was done as a sham treatment. So these patients were put in the hyperbaric chamber and pressurized to a very low pressure. So they thought they were getting treated. And but they weren't actually receiving hyperbaric oxygen treatment. So in other words, it was a convincing placebo to try to filter out any effects that might be there just from having experienced some treatment. They then did follow-up at 3 months, 6 months, and anywhere from 1 to 5 years. The average follow-up was 2 years, and the minimum follow-up was 1 year after finishing the treatment. And then they looked at already validated and kind of established follow-up measures for patients with radiation proctitis, which is a multimodal score. It's called, abbreviation is SOMA-LENT, but it includes things like subjective, like patient-reported outcome measures, objective measures, as well as clinical assessments. As a secondary outcome, they looked at bowel-related quality of life measures, which also obviously is very important from a patient perspective. So in this study, they found that complete healing or some improvement in symptoms was observed in 88.9% of the patients, as compared to 62.5% of the patients in the non-hyperbaric arm who were getting other standard treatments. So the conclusion was hyperbaric oxygen therapy for patients with chronic refractory. Chronic refractory means they failed other treatments. Radiation proctitis resulted in significantly improved and enduring healing responses and enhanced quality of life. So that's, and again, I didn't want to kind of go a little bit too overboard on boring science stuff, but I'll just kind of wanted to just have the time to also share with you a little bit about what does a treatment look like, because I was identified in the list of questions that Norm shared with me. So Vancouver General Hospital, where I work, it's the provincial resource for hyperbaric oxygen therapy. It's publicly funded, so the treatments we provide are covered by our medical services plan. And as a result, we have the onus to treat evidence-based conditions. So we serve patients from all regions of BC, and the data is from 2 years ago. We were doing about 3,800 treatments a year. We have the capacity in our main treatment block to treat 2 stretcher patients or 8 seated patients. And so it is a pretty, as far as space-wise, we're very lucky to have a good size chamber. So the issues around feeling confined or claustrophobia are much less than in places that have very small one-person chambers. And so our elective patients, so most of our radiation bowel bladder patients, they're patients that they live at home and they come in daily for their course of treatment, and they sit in chairs. The room is pressurized with air, and then they breathe 100% oxygen through these hoods. So actually, while they're on treatment, they're self-contained. So this kind of became more of an issue during COVID-19. So where we instituted a lot of screening protocols and temperature checks, and worked with our Vancouver Coastal Health Infectious Prevention and Control team to remain operational throughout. We never had to shut down completely, but we did reduce capacity for a while and then built it back up. But once the patients are on 100% oxygen, they're actually breathing in 100% oxygen from outside the room, and what they breathe out gets dumped outside the building. So they're actually like on a self-contained breathing apparatus while they're on treatment. And the treatment profile looks like this. So this is the pressure. So we describe pressure in feet of seawater because there's a bit of a history in hyperbaric medicine of treating scuba divers and tunnel workers, who built some of our bridges back in the day manually, in pressurized environments that would get decompression sickness. So we go from 0 feet seawater to 45 feet seawater pressure, which is 2.4 atmospheres, over 10 minutes. So that 10 minutes is to give people time to clear their ear pressure. So people do maneuvers like pinching their nose, yawning, swallowing water, much like you might experience in an airplane landing. So when you're landing in an airplane, the pressure is actually increasing, much like it is at the beginning of our treatment. And so you do maneuvers to equalize your ear pressure. And we know 90% of people can do that, 10% struggle. And then once they're at depth, they then go on, the green is 100% oxygen for 30 minutes. We then give them a 5-minute air break, another 30 minutes oxygen, 5-minute air break, 30 minutes oxygen. And then there is a gradual depressurization back to surface pressure. This gradual part, it's actually for the benefit and safety of the nurse that's accompanied the patients in the hyperbaric chamber. So unlike the patients are breathing 100% oxygen most of the time, technically it would be very safe for them to be brought out quickly at any point. But the nurses have been breathing chamber air. The chamber is pressurized with air. So physiologically, for them, it's like they're doing a scuba dive. And so they can't just come straight to the surface without some risk of actually decompression unless they bring the air, which is 79% nitrogen. That nitrogen uptake needs to be breathed out gradually as they surface in these stages. So that's sort of the reason we have that. And so if at any point a patient had to come out, we have a transport lock where typically I would go in through that lock, pressurized to 45 feet, and accompany that one patient out through the second lock to depressurize the surface. The rest of the patients would stay there, and that's sort of, so this is to provide efficacy for the patient, is the oxygen periods, and the safety for the nurse being in there is return to the surface. Now, I want to also kind of share with you a little bit about a typical patient journey. And I should mention that for radiation cystitis and radiation proctitis, the treatment course is typically 40 treatments, each treatment being 2 hours and 15 minutes. And we're doing these Monday to Friday. So you're typically there for a morning or an afternoon, Monday to Friday, for 8 weeks. So it is a pretty significant time commitment. And that's one of the things that we discuss with the patients when they start. We have about a 3 to 4 month waiting list currently. So it does give people to do some planning. And for our out-of-town patients, they often will arrange accommodations at the Cancer Lodge or other, we provide information for them about that. But it is a pretty significant time commitment. But I want to give you a little bit, and I'm going to just share with you a typical patient journey with radiation cystitis. And I'm going to be totally honest here. I'm not trying to sugarcoat this because, our waiting list does create some challenges. So patients will, one of the initial symptoms will be bleeding in the urine, and they'll see their urologist. They'll typically have a cystoscopy, and they'll see, okay, thank goodness there's no cancer recurrence. Everything is okay there, but they can see evidence of late radiation damage to the lining of the bladder. And so they will then refer them. So they may try some things first, but ideally, we would love to have them be referred within 6 months of their symptoms starting. We know that patients have better outcomes if we start earlier rather than if it's been a long time. But there's a referral, and we prioritize these. So we typically do a consultation within a week for these patients. So we either do it virtually if they're from out of town or in person. And then once that consultation is done, if they are a candidate for treatment and they want to have treatment, we put them on our waiting list, which, as I was mentioning, is about 4 months. Now, not sugarcoating things. Sometimes these patients do bounce in and out of the emergency department during this time with recurrent bleeding episodes, and may require bladder irrigation, cautery, chemical or electrical, and they do sometimes require blood transfusions or return to the operating room to control the bleeding. And then the hyperbaric oxygen treatment course, as I mentioned, is 40 treatments. And based on the data we looked at, it's consistent with what we experience is about 80% of patients do have a positive response within the treatment course. I would say about 10% of patients have a response where we make a decision with them to extend their treatment up to a maximum of 60 treatments, so 20 additional treatments. Sometimes there's a bit of a gap between us getting them at that additional 20 treatments because of our wait list. So this is part of our reality, but we are working on shortening this wait list. But like many other things in our system, there are some things that are out of our control, like just our capacity and the demands. So, but the case that I keep making with our, hospitals is actually the delays. They not only result in adverse outcomes for the patients, but they do result in avoidable costs in our healthcare system. So actually, there is a value proposition to avoid all these ER visits and hospitalizations and returns to the OR and hospital stays, which are quite expensive, with more proactive early access to treatment. So I'm going to just get off my soapbox for a sec now and just talk a little bit about risks and side effects of treatment as well. So the most common, one of the two common things that we see is difficulty with ear equalization. So in the published literature, that's about 10% of patients. We know in that first 10 minutes of the first treatment, they're going to have difficulty equalizing their ear pressure. We can usually coach people through it and give them decongestants. But if there's something we can't correct, then we would ask one of our ear specialists to put some small tubes in the ears. And this is similar to tubes that some children have to get for recurrent ear infections. So what's happening is this is your outer ear and the ear canal and your eardrum. And this is all closed, right? So this is a complete closed area. And then this middle ear space where conduction of sound occurs to the nerves, it's an air space and it communicates with the back of your nose and through this eustachian tube. Can you guys see my arrow? Yeah, okay. So what you're doing when you're landing in the airplane is you do maneuvers to push air into this middle ear space. As the pressure is increasing, the eardrum's bulging in because the space volume's decreasing. So you're adding more volume to equalize that, and then you're fine. But if somehow this is blocked up, you start to get the eardrum bulging in, it becomes painful. You're going to tell us, my ear's hurting. We stop pressurization. And if we can't get you to equalize, then we cancel the treatment. We surface the chamber and you come out of the treatment, and then we send you to get the tubes done, or we wait till you're cold or your allergies or whatever is maybe a temporary thing is resolved. It's very rare with keeping an eye on people's symptoms to actually cause any permanent damage to the ears. So that, in my experience, it's less than even 2%, but in the reported literature, they talk about 2% of patients get some redness, or actually in very severe cases, rupture of the eardrum if the symptoms are ignored. Similarly, the other place you've got air pockets is in your sinuses, in your face, right? So you've got these sinuses that are full of air. They also equalize at the back of your nose. And those ones, fortunately, it's much more rare that people experience any difficulty. The openings to those are usually open. But if somebody's got allergies, we usually put them on steroid nasal spray and try to optimize that before they actually start treatment. The other thing that's common is 30% of patients will notice some changes in their visual acuity. It's a dose-related effect of hyperbaric oxygen. So the typical pattern is that near vision improves. So you maybe don't need your reading glasses as much once you're into the treatments, but your distance vision gets worse. So you might need stronger prescription for driving or for watching TV. And this is a dose-related effect. So if you're one of those people that ends up needing full 40 treatments, or that 10% that maybe go on to have 60, more people are going to notice that. Overall, it's 30%. But once the treatments stop, in most cases, it gradually drifts back to where it was before. So we tell people, don't invest in a very expensive pair of glasses mid-treatment if you're going to update your glasses. About 2% of people can have confinement anxiety. So that feeling of being in a small room with a number of other people, I usually liken it to being in a short haul flight, like within BC, those smaller planes, or being in a hospital elevator with a few other people. That if that makes you feel anxious, you might also feel anxious in the hyperbaric chamber. We do a very detailed orientation session with one of our nurses prior to patients starting, to go through all the clothing and actually look inside the hyperbaric treatment area. And often that education relieves a lot of the anxiety of the unknown. And occasionally, for the first couple of treatments, some people do need some medication to help them with the anxiety. Now, getting into rare things, in the literature, there's a 1 in 10,000 reported risk of hyperbaric oxygen triggering a seizure. This is related to the actual too much oxygen causing toxicity. And in our experience, in the almost 20 years I've been in the unit at VGH, I've only ever seen this happen a couple of times in patients that had epilepsy. So they had a seizure disorder and we triggered a seizure while they were in treatment. The oxygen's removed, the seizure would stop. But this is why there's always a nurse or physician accompanying the patients in the treatment. For diabetics, we do a blood sugar before and after their treatments, because hyperbaric oxygen has an effect to lower blood sugar. So we don't want people going in with a low blood sugar and then dropping further because of an effect of hyperbaric oxygen. So, and as I mentioned, we get a lot of calls from patients and sometimes from other physicians to ask us to treat off-label things. So these are things that the evidence isn't necessarily there yet. More studies need to be done. We generally can't accept those. So we stick with Health Canada approved conditions that there's evidence for. Which are, and if we're going outside of that, it's in exceptional cases where there's a strong push from their specialist, and then we our team has to have a team conference and consider a case-by-case basis. But generally, we stick with these Health Canada approved evidence-based conditions. And so this is just to give you the big picture overview of that we sometimes get patients that have had an air stroke. So these are typically from the operating room. They're having open heart surgery for coronary artery bypass or valve replacement, where the heart's actually opened briefly and air accidentally gets in there and it goes into the brain and blocks the blood vessels and causes an acute stroke, but it's due to air instead of clots. So those patients are like an emergency into the chamber. The other thing is we treat patients with chronic wounds, typically with diabetes, that have microvascular blockages causing their wound not to heal. The other emergency is carbon monoxide poisoning. We have patients with soft tissue, skin and soft tissue necrotizing soft infections. So this is in lay terms known as flesh-eating disease. So we get maybe 2 or 3 cases of that a year. We have patients that have had surgery by plastic surgery typically, or to cover up a tissue defect with a graft or flap, and the tissue doesn't have enough oxygen to take. So we get these are urgent. So we typically get these referred within a few days after their surgery where their graft or flap is failing. And in some cases, we can help. The other one is in some very severe crush injuries where a limb has been crushed traumatically. We provide some support for that. Decompression sickness. So this is scuba divers who develop decompression sickness. We talked about delayed radiation injury in those different parts of the body. Sudden sensorineural hearing loss is a specific type of sudden acute nerve hearing loss that responds well to hyperbaric oxygen therapy. Brain abscesses, necrotizing soft tissue infection is another subtype of flesh-eating disease. And refractory osteomyelitis, so these are patients that have infection in bone and it's chronic. And the refractory part means they have failed 6 weeks of IV antibiotics. So these are severe refractory cases, meaning they haven't responded to standard first-line treatment to 6 weeks of culture-based IV antibiotics. So we typically will coordinate a course of hyperbaric oxygen therapy with some surgical cleaning out of the dead bone in the bony area that's affected. And then the other kind of really rare ones that severe anemia, these are typically patients that for religious reasons cannot accept blood transfusions, but they've had a sudden bleed for some reason. And essentially they're going to die from lack of blood. And so these are very special cases where we intermittently provide hyperbaric oxygen to help them survive and have oxygen to have their tissues not have irreparable damage, while their own body is stimulated to produce blood to replace the lost blood. So typically we're supporting them for about 9 days while that's happening to prevent irreparable brain and heart damage. And then severe thermal burns, again, it's not very common that we treat that, but that is an accepted indication. So that's, I'm going to just stop sharing so we can see each other. Okay. And I will just I'll look at the chat and I'll open it up to any questions.
I wanted to ask if there was any Wi-Fi's in the chamber.
No, there you went, because the chamber is a steel vessel with a very thick wall engineered to withstand 100, it can withstand we do treatments for some emergencies up to 165 feet seawater for those air strokes. So that is actually 6 atmospheres pressure. So imagine this thing is engineered to, like, the windows are like several inches thick, right? So so in other words, we have Wi-Fi in the unit, but we don't have Wi-Fi in the chamber. And then the other more important reason is this, and thank you for actually bringing this up, is lithium batteries in our phones are a strict no-no because they can spontaneously produce heat and combust. So one of the things we do in the orientation session is go through a very stringent process of making sure nothing that's potentially a risk for causing fire goes in our hyperbaric chamber. And then actually every day we ask people, it's like going through the border. They ask you, do you have any contraband, going through the border? So we're very strict. I mean, we've had a program here for about 55 years now. We've never had a fire. Obviously, that would be catastrophic. So we don't want to ever have that. And but the reason that's not going to happen is because we are very strict about anything, even if it's theoretical. If there's an important reason for it to go into hyperbaric chamber, then our biomedical engineers go through a very standardized process of validation to make sure the device, it can remain functional and is safe to be in the chamber. And an example of that is our ventilator for those critically ill intubated patients coming from the operating room. Our ventilator actually, had to go through that process, but any other pumps or anything that's really crucial for care, we put through that. But quick answer is, sorry, no Wi-Fi. You can't do but you can read a book. So a lot of our patients read books, and we have some flat screens in there. Patients watch movies with headphones. So it's kind of like being on a plane. And so the patients get to take turns choosing the movie. So there are, 8 patients at a time. So they take turns choosing movie, and it creates an element of fellowship and camaraderie, in consulting with each other and choosing a movie. And they basically 2 hours and 15 minutes long enough usually for one movie.
So a supplementary question to that, if I may.
Yes.
What about other metal products that we may have in our bodies, like steel plates and
not a problem.
lasers? Okay.
Yeah, anything that's internal to your body is okay. The exception is things like pacemakers. So what we do with pacemakers, the issue isn't that it's going to cause a fire or safety problem for the chamber, but we need to check the pacemaker. From the manufacturers will actually have data on the pressures that pacemaker is allowed to go up to. And nowadays, modern pacemakers, it's very rare that we would exclude a patient from being a candidate based on their pacemaker, but we will check it as part of our screening and make sure that we're not going to harm or damage their pacemaker by exposing it to pressure.
Norm, you have a question? Unmute.
I'm sorry. Two-part question. Dr. Khazei, from the 3,800 patients that you deal with each year, what percentage of them do you estimate come in with either radiation cystitis or radiation proctitis?
That's a good question. I don't have the exact numbers in front of me, so I'm going to just give you a rough number, right? So of those patients, probably about 50% are sudden sensorineural hearing loss, and about 30% are late radiation effects, of which the most common is radiation bladder. The second most common is radiation proctitis or bowel. And the third, second is radiation proctitis would be third. The second is head and neck radiation effects of the jaw and oral cavity. So that all the radiation patients taken together, it's about probably 30% of our elective patients.
The second part is in discussions with my fellow travelers at the unit with radiation cystitis, is that we were at a loss to recall or find information prior to our radiation treatment that identified late radiation cystitis as a potential problem. The acute radiation problem was identified. Can we do, or can groups like BC Cancer do a better job of making us aware of the potential for this problem occurring, so that we don't go into a panic like I did when the onset came? And it's sort of that's a sort of a soapbox question at the same time. But can we as collectively help BC Cancer understand the potential, the likelihood of this happening to many of us?
So, My experience has been that most of the radiation oncologists at BC Cancer Agency, they are really fully aware of this, and they tend to refer the patients to us once they recognize this is what's going on. I think where there are more gaps and opportunities for advocacy is with some of the, like say, the urologists or gastroenterologists or head and neck surgeons, plastic surgeons, that sometimes what we're experiencing is we're getting a referral. It's been 2 years of repeated cauteries and chemical treatments and in and out of hospital and a lot of damage in the process to the tissue. So that's where we sometimes, I try to, in my consultation note, obviously in a respectful way, provide that feedback, to just sort of say, we obviously this patient's a candidate, but there is some evidence that earlier treatment results in better outcomes. And I think that's where sometimes I think there's a lack of awareness about this being an option. And so I think patients can be effective advocates in bringing this question forward also with their doctors who may have varying amounts of awareness about it.
Okay. Thank you.
Frank, you have some questions?
Are there any other chambers other than the one at VGH? And is there any private chambers that you could go to if you wanted to try it?
There are some private chambers in BC. I don't know. I probably don't know about all of them, but the ones that I know about, I think they serve a kind of a public demand for unproven indications. And I think that there's definitely a sort of a off-label, the things we can't treat. I think some of the things I have to kind of be transparent about is generally the level of oversight and safety standards is a bit variable. And in that they're not required to have, for example, accreditation in the way that, a hospital-based facility. So we undergo accreditation. We are accountable externally to make sure we're meeting certain safety standards. And then I know some of them also there's not like medical people involved. You see what I mean? So again, I don't want to, it's difficult for me to endorse any of them because it would be, so you'd want to make sure you do your due diligence to make sure that it's being done safely and responsibly.
So yours is the only hospital grade chamber in the province, it sounds like?
That's correct. Yeah.
Okay.
So we're the only hospital-based. There is a military hyperbaric chamber in Esquimalt at CFB Esquimalt in Victoria, but
Okay.
they only treat basically decompression sickness in Navy divers. So on occasion, so basically that's the only other kind of publicly funded chamber.
Sudden hearing loss, sorry to add another question in there, but that sort of surprised me. Is that any idea why you would use a hyperbaric chamber for that?
Yeah, great question. So the studies around sudden sensorineural hearing loss, they came out about 5-6 years ago. And so it's now one of the conditions. So the American and Canadian ear, nose, throat specialty organizations listed as one of the 3 evidence-based treatments for sudden sensorineural hearing loss. And so actually that's one where that's why it's kind of taken over our program, is we get a lot of referrals. How does it work? Well, there's some unknowns, but sudden sensorineural hearing loss is similar to Bell's palsy, which is a little bit more, people are familiar with that because we know people like Jean Chrétien and other people who've had sudden loss of nerve function in the motor nerve of their face. Okay. Sudden sensorineural hearing loss is similar in the mechanism to that, except the nerve involved is the hearing nerve, which is very close to the facial motor nerve. And it's an autoimmune condition. So it's your immune system having an exaggerated response and actually attacking the nerve. We know some things about what that can trigger that is sometimes a virus can trigger that exaggerated response. And in other cases, it's not known what the trigger is. Okay. We do see associations where people have had a recent viral infection and then they get Bell's palsy or sudden sensorineural hearing loss 2-3 weeks later. That association is well documented, which is why there's this viral theory. And then we also see in patients with, say, rheumatoid arthritis, lupus, other autoimmune conditions, that they're a higher risk for not only getting these nerve immune problems, but also getting them recurrently throughout their life. And so the treatment options are prednisone, so an acute course of high-dose prednisone, which suppresses the immune system, injections of prednisone like medications directly through the eardrum into the middle ear space, which is next to the hearing nerve. And the third is hyperbaric oxygen. And then in the studies looking at this, patients that got steroids alone had a 50% response rate. When you add hyperbaric oxygen, the response rate is 70%. So it's not 100%, but it's significantly better than steroids alone. So that's kind of where we sit. So there's some unknowns. What are the mechanisms by which hyperbaric oxygen works in an autoimmune condition? Two ways. So one is it actually does work on white blood cells at the level at which they're binding to the inside of the small blood vessels, to receptors there, crossing over into the tissue and then releasing inflammatory mediators in the tissue. And some of these inflammatory mediators are thought to propagate the damage done by the condition. The second thing that happens is there's hypoxia of the nerve while it's inflamed. And so the hyperbaric oxygen can also support some nerve function while the inflammation is settling. These are some of the things we know. And I think there are probably some things we don't know that we're going to learn more about. That's kind of the extent of it. I'll mention one other interesting thing is during COVID, we've seen more cases of sudden sensorineural hearing loss, which supports that viral theory. But, you know, and then also there is a multi-center randomized control trial to look at the effects of hyperbaric oxygen therapy for COVID-19. We were asked if we would participate. We couldn't because we have our capacity is completely, we're full. We can't do anything like that. But Ottawa, Toronto, and a unit in France and a unit in US, they're actually doing randomized studies to look at the autoimmune damage that occurs for some COVID patients, whether it can avoid them having to end up in the ICU. So some very interesting, but some unknowns also.
That's a wow.
Mm-hmm. Mm-hmm.
Mark, you had a question? You have to unmute though.
Sorry about that. I had brachytherapy about 20 years ago, and it is my suspicion that my bladder has lost its elasticity dramatically. I go every 2 hours, 24/7. And I just wondered if that's a reasonable side effect or outcome of brachytherapy.
Yes. So what you're describing is a delayed radiation effect where the bladder wall is thickened and its elasticity is decreased. So it has a smaller fixed volume and a reduced ability to stretch. And that is a known documented cause effect of delayed radiation effects.
Is there anything to do with it? Or is it just the way it is? I mean, I'm 80 now. I don't know if I want to bother, but I'm just asking.
Yeah, no, that could benefit from a course of hyperbaric oxygen therapy. So yeah, that's again, looking at those mechanisms of remodeling in the bladder wall, angiogenesis, new blood vessels growing in. It is possible to get some benefit from that. Most of the patients we treat are more severe, like they're having a lot of bleeding and clots, but it doesn't mean that. I think as far as eligibility criteria, you would meet eligibility criteria to be, if obviously other causes were excluded, then that you would meet eligibility criteria for treatment. And then what we typically would do is screen to make sure there's not some other health condition that you have that would preclude you from having safe treatment.
So, and you say 40 treatments, that's 8 weeks, basically.
Correct. Yes. Yeah.
So you have to make an 8-week all-day commitment.
Pretty much. I would say they're okay. Some patients respond faster. So we do have maybe about 20% of patients that after 20 to 30 treatments, they've had a complete response and we would stop early. But I would say majority of patients are requiring the 40.
Yeah, so it's a major commitment, isn't it?
It is. It is. Yeah. And it's particularly impactful for patients that are from out of town. And I think that is a big thing to consider when people are making a decision, about the treatment.
What is it? Whole afternoon or all day, or what are we looking at?
So typically people are here for about 3 hours. So the treatment's 2 hours and 15 minutes, but you get here, you change, we check every patient before they start their treatment. We check their blood pressure, pulse, if they're diabetic. We do their blood sugar, at least the first few treatments, to make sure they're not going in low. And then, so the total time you're here is about 3 hours, Monday to Friday.
What? So you do 2 a day, I guess. 2 sessions.
No, we're typically doing 1 a day. And occasionally there may be a cancellation due to emergency cases. And occasionally there's a cancellation because we get so many urgent starts, like those hearing loss patients are urgent, that we end up having to do rotating cancellations because we've got kind of a limited number of spots within our program, because the patients go in cohorts of 8. So like every seat's full, that usually, right? So, but if we kind of have excess demand, somebody might lose one treatment a week kind of thing. We spread that around. So
I see. Yeah, it's something to think about.
A couple other questions online or in the chat was how many grays would someone know that they were getting? Would they be asking their oncologist how many grays?
Yeah, so that would be that's well documented in the medical record at BC Cancer Agency. So anytime I get a referral, that's part of the notes I get from the cancer agency. It'll say when radiation happened and how many total dose in how many fractions.
How does a patient know?
Yeah, I don't know that patients often know or would remember, to be honest with you. I think to find out, I think you can call the cancer agency and ask for that. Or often your family doctor would probably have been copied on notes from the cancer agency, as part of being so if your family doctor has those notes when you're in, you could ask them, how much did I have? And they might have those in your medical record.
Would they not have that information up front before they take the treatment? So we'll provide you with the regular treatment of 6,000.
Yeah, I think that, I'm not a radiation oncologist, but I know that they will usually plan the minimum dose required. And, they've come a long way. They've come a long way in trying to use CT imaging and modern radiation delivery systems to minimize the dose, to make sure the dose is mostly hitting the cancer and reducing collateral damage, right? But even with all of those best efforts, there's still some collateral damage surrounding normal tissue. And then sometimes, as you may know, is patients have an initial treatment and then there's a recurrence. They sometimes have to have another course. You see what I mean? And then the dose starts to accumulate. So it's a cumulative lifetime dose to that particular tissue.
It's not really an easy one to deal with.
No,
the other question related to that is, or maybe you don't know the answer to this one, is for brachytherapy. Do you happen to know the number of grays that are given to the patient?
No, and I don't know if there's a standard. So that would be a good one for the oncologists, that are dealing with that and I suspect it depends on the grade of the cancer and even like the patient size of the patient, those kind of things.
What time is it now?
Sorry, if they're having conversations offline, can you please mute yourself? If you're having conversations offline, please mute yourself. If you have or a urinary problem, or if you're going to the bathroom every 2 hours to empty your bladder, can you seal or seal in a chamber? No, I don't. It's just if you're having to go to the bathroom every 2 hours, I think there's another problem that needs to be dealt with in this case. Anyway, this person is going to having to eliminate every 2 hours.
No, that's a very, that's a common and important question. So generally, I mean, obviously a lot of our patients struggle with this. It's not an uncommon thing. So what we typically do is give people an opportunity to go right before. And then if there's an urgent situation, our chamber, which I think I showed it in one of the pictures, it's like a long cylinder. It has 3 compartments. So the main compartment is where the patients are getting the treatment. And then there are 2 other compartments with doors leading into them from the chamber. So in the event that somebody had to go in the middle of a treatment, we would just pressurize the second compartment up to the treatment pressure. They can slip behind a door. There'd be a commode there. And then they can do the business and then come back and resume their treatment. We try not to plan on it being a daily thing. I think it can be hard to have to do that every treatment for the staff. But if it's once in a while, we've got a plan for that.
Okay. Frank, would you want to ask that question, Frank?
Well, I was
Yeah,
just
yeah,
going to comment that it's 66 grays for salvage and 70 grays for primary radiation treatment for prostate cancer in particular is what the standard has been. And of course, that falls right within the, I think the 60 to 70 that you can expect. I think it was somewhere around 10% having problems from the radiation. So I guess that's probably what we feel it would be among our group.
Yeah. So I think the 6 gray to 7 gray, like 6,000, 7,000, it was 1.8 to 5%, and then over 7 gray, it was 9%. So
Right.
those are sort of the numbers from the literature. Yeah.
So Ross, do you have a question? Unmute yourself, please, Ross. There, you're on.
Yeah, thank you. So I was asking that exact question about, so normally I had salvage radiation, which was 33 visits. My primary treatment was surgery and then cleanup radiation for 33 visits. How many grays do you think I had on average total?
I can't say because it really depends on the dose per fraction. You see what I mean? And it is a bit of an individualized thing. It's not a one size fits all. So
Well, I
I would
think-
just check with the BCCA, like with your oncologist. They would have that on record. What you
Okay,
have.
I'll do that. But then, so I wrote down the 10% likelihood of it's over 7,000 in the middle category of radiation received. It was a 1 to 5%.
Yeah, it was 1.8 to 5% in that group. That was yeah.
And that group again was how many?
That was 6 to 7.
6
6 to 7 gray, and then when we put the centi makes it 1,000, right? So 6,000 centi to 7,000. Yeah.
Thank you.
Did I get all the questions on the chat? I'm sorry if and Len, thank you for moderating. So please let me know if I've missed any questions.
I think we got them all. Wait a minute. For cancer patients, is there a benefit for breathing? Another question I had, this is probably related to this one. Are all of us in the same category in terms of oxygen in our levels of oxygen in our bodies, or are we all variable?
Mm-hmm. It's variable because all of us, our heart and lungs and our circulation all impact what our baseline circulating oxygen is, right? So just to give you kind of an extreme example, let's say you've got some heart disease and you've got some blockages in the blood vessels due to atherosclerotic plaques. And let's say you have emphysema or heart failure where your lungs aren't exchanging gas as efficiently. You see what I mean? So your baseline may not be kind of the 60 to 70 millimeters mercury arterial oxygen level that a healthy, fit person would have breathing air. You see what I mean? It also would limit how much it goes up with breathing oxygen because there's a kind of going to be a transfer capacity limitation. But regardless, there would be some increase. But in very severe cases, it may actually limit the efficacy of treatment if somebody's got significant problems. And this is part of the considerations when we do the medical screening, is make sure that there's actual reasonable likelihood of benefit and then to use the resource, but also that it's safe for them. Because there are some medical conditions that can, you know, like the diabetes being an example, the blood sugars can drop. You know, there are some other things like that that we have to take into consideration for medical screening.
So would there be some benefit of taking on some extra oxygen into your body if you have prostate cancer? Breathing some extra oxygen?
So generally, you know, stimulating angiogenesis, you need that much higher levels. So you need that, like, you know, that levels like I showed you that are going to create the kind of almost like at that level where we're doing the hyperbaric oxygen therapy, it becomes like a drug. You know, it's and that's why there's side effects. So it's, you know, it's not, it has effects, it has side effects. So, and unfortunately, just breathing oxygen at surface pressure, it isn't enough of a dose to stimulate those effects to occur.
So being very healthy might be just taking exercise, maybe the benefit that we get from increasing their oxygen level by doing some exercise.
Absolutely. Yeah, absolutely. And I think, I mean, one of the challenging things is some patients do notice that vigorous exercise triggers their blood in the urine. You know what I mean? So then they become really limited in their activities, which are so good for the rest of their well-being and quality of life. And so it becomes kind of you know, very impactful for them.
We have one other person.
Len Ken Livet has been holding up his hand. I guess he doesn't
I see.
doesn't know how to use the other button.
Ken Livet?
Can I speak? You can hear me?
Yes.
Yes, Ken. Yeah.
It took 72 days for me to complete my 40 sessions. A lot with high norm. That includes weekends where there was nothing going on and getting bumped and maintenance days. So I thought I did quite well in 72 days. I can't think I can't say enough about the quality of the staff and the caring. Absolutely amazed me.
Well, thanks, Ken, for that feedback. That means I think our team takes a lot of pride and cares a lot about what we do. So thank you for that. I think that's very meaningful feedback, and I'll share that with our team with your permission.
Great. Dave Kennedy has a question. Dave, you're muted. Okay, Dave.
Yeah. In the summer, I had blood in the urine for about a little more than 2 months, I guess. It was consistent. I was scoped and they really didn't find anything. It resolved spontaneously, and in the last 7 months, I've seen nothing. So I don't think I'm a candidate for hyperbaric, but I'm interested to know all about it, and I thank you for your information.
My pleasure.
Ross, do you have another question?
Yeah, thank you. I'd like to ask Ken, has he seen an improvement in his conditions that got him into the hyperbaric unit?
You're asking me?
Yeah, Ken. Yeah. Have you seen
Actually, that's an interesting question. My symptoms had stopped several weeks before I went to hyperbaric. So I think there was no improvement. Probably physiologically there was. I felt no change from stop to ending. And I believe because of the, it stopped before and the oxygen probably made my bladder and rectum stronger. And I've had no blood for several months.
That's good to hear. Well, thank you. I think you are on a time limit there, Doctor. And I want to thank you on behalf of all the guys that this was absolutely tremendous. And it's opened a door that we never thought about. So it's very, very helpful for us to understand. So on behalf of all the guys, thank you, thank you, thank you, thank you.
It's my pleasure. I thank you very much for everything you're doing, and it was my pleasure to connect with you.
Thanks again. And well,
Bye-bye.
stick around. I'll let you get on to your next task that you have indicated. You're
Thank you. Yeah, the afternoon patients are coming shortly. So take care.
Right.
Bye-bye.
Bye now.